First of all, I thank Dr. Minaj sir for giving this opportunity. My today's topic is regenerative medicine in PMR. Actually, regenerative medicine is evolving branch that not also relieve pain, but also structural and functional improvement of the tissue which we are treating. As a PMR specialist, ये बहुत important है because our goal as a PMR specialist always is a functional recovery, long-term rehabilitation, and improve quality of life. So in this session, I'll cover PRP, BMAC, micro fragmented adipose tissue, stem cells based approach, their indication, mechanism of action, some rehabilitation protocol after these procedures, and some ethical or medical legal aspects. For exam point of view, this topic is very important. In previous exam, at least one question have been asked in every MD or DNB exams. These are the last 5-year papers of DNB examination. So start with the definition. Regenerative medicine is an interdisciplinary therapeutic approach that aims to repair, replace, regenerate or rejuvenate lost, damaged or diseased cells, tissue or organ to restore or establish normal form and function. And what are the orthobiologics? The use of biological substance to enhance biological healing of orthopedic injuries or alter the natural course of an orthopedic disease. In PMR perspective, we emphasize is on musculoskeletal and neurological disorder, aiming for pain relief, mobility, restoration, and improved function. If we talk about the history, in 1992, the term regenerative medicine given by Kaiser. In 1998, human embryonic stem cell first isolated. In 2006, induced pluripotent stem cell discovered by Shinya. And since 2000, orthobiology is very much used in musculoskeletal conditions. So think like a farmer, we are farmer, like seed represent the potential to grow new life. Soil gives supports an environment for the growth, and fertilizer provide nutrients and signals to enhance growth. Just like farming need all three to be successful, in regenerative medicine we also need to these basics component to regenerate tissue. Like seeds are cells, mesenchymal stem cells, stromal cells, soil scaffolds, biological synthetic structures that support cells, fertilizer, growth factors. Together these form the triad of the regenerations. So without one, the process is incomplete, just like farming cannot succeed without seed, soil, and fertilizers. Now, classification which is given by Mason and Dunnell in 2008, they describe regenerative medicine as comprising 4 pillars: cell therapy, these are transplantation of the live cells, stem cells, chondrocytes; tissue engineering, combination of cells plus biomaterials scaffold, biomaterials scaffolds, natural synthetic materials that support cell growth, tissue repair; and biologically active molecules like growth factors, cytokines, PRP, and exosomes. Now PRP. So PRP is an autologous concentration of platelets in plasma obtained from the peripheral blood after centrifugation, containing a platelet concentration above baseline. It delivers high amount of growth factors and cytokines that stimulate tissue repair, angiogenesis, and anti-inflammatory effects. We all know about the RBCs, carry oxygen to tissue, white blood cells defend the body against infection and modulate inflammation, and platelet helps in clotting and importantly release multiple growth factors that promote healing and tissue regeneration. This is the foundation of the PRP therapy. These are the growth factors which is found in the platelets, transforming growth factors, fibroblast growth factors, platelet derived growth factors, epidermal growth factors, vascular endothelial growth factors, connective tissue growth factors, insulin-like growth factors, platelet factor, interleukin, or keratinocyte growth factors. For exam point of view, you have to memorize this growth factor. So if we classify the platelet, PRP, so this is a leukocyte-rich plasma, contains high leukocytes. These are the more inflammatory, preferred in the tendon and ligament injuries. And the leukocyte-poor PRP, fewer leukocytes, less inflammatory, preferred intraarticularly, OA, and cartilage. On the fibrin architecture, pure PRP platelet concentrate without leukocyte, low density fibrin, and leukocyte PRP contains leukocyte, low density fibrin. Platelet rich fibrin, pure PRF, platelet concentrate without leukocyte, there is a strong fibrin matrix, and leukocyte PRF contain leukocyte plus platelet in strong fibrin matrix. On activating method, activated PRP platelet activated before injection, immediate release of the growth factor, and non-activated PRP, which commonly use platelet activated in vivo after injection, sustained release. If we talk about the function, what are the function of the PRP? These are the mitogenic activity, stimulate DNA synthesis and mitosis, and chemotaxis, recruit reparative cells, synthesis of the proteoglycans and extracellular matrix, which improves cartilage and tendon healing, and osteoblast and chondrocyte proliferation, which improves bone and cartilage regenerations. Collagen synthesis improve tendon ligament strength and repair quality, and angiogenesis, vasculogenesis, new blood vessel formation for the better healing, and stimulate synovial fibroblast and high hyaluronic acid synthesis, joint lubrication, and better cartilage environment. Some contraindications before the PRP use, like absolute contraindication like platelet dysfunction syndrome, critical thrombocytopenia, hemodynamic instability, septicemia, local infection at procedure site, and patient not willing to accept risk. Some relative contraindications, consistent use of NSAID within 48-hour procedure, because it hamper the action of PRP. Corticosteroid injection at treatment site within 1 month. Systemic corticosteroid use within 2 weeks. Tobacco use, recent fever or illness, any cancer, if hemoglobin less than 10 and platelet count less than 1 lakh. Now, how PRP is prepared? PRP method simple, based on centrifugation of the whole blood, yields plasma with platelet concentration above baseline. Second is the Buffy coat method. After centrifugation, the Buffy coat layer is harvested, contain platelets and leukocyte. And third is the plasmapheresis. Use apheresis machine for continuous blood processing. Produce large volume of standardized PRP, typically used in the blood bank research setting, less common in clinical practice. The platelet-rich PRP method, obtain whole blood into the ACD tubes, do not chill blood before during the platelet separation, centrifuge blood using soft spin, transfer supernatant plasma with platelets into another sterile tube without anticoagulants, and centrifuge again at a higher speed and to concentrate platelet. Result, lower 1/3 is your PRP and upper 2/3 is a platelet poor plasma, and platelet pellet form at the bottom. Suspended platelet pellet in 2 to 4 ml plasma by getting gentle shaking, and this is the final product of PRP. And Buffy coat method, store whole blood at 20 to 24 degrees centigrade before centrifugation. Centrifuge at high speed, and layers formed by density. The bottom is RBC, middle is Buffy coat, and top is a PPP, platelet poor plasma. Remove supernatant plasma from top and transfer Buffy coat layer to a new sterile tube. Centrifuge at low speed to separate WBC, or use or leukocyte filtration filter. There are two methods of the open method and closed method for formation of the PRP. The principle of the open method is use ACD vials, conventional test tubes, centrifugation, single or double spin. It is advantage cheap, the low cost method, but disadvantage higher chance of the contamination, time consuming, required trained staff, and no temperature control possible. In PRP, first blood collection about 34 ml of whole blood is drawn, collected in the anticoagulant vacunator tube. First spin, I told in the previous slide, centrifugation separate plasma into layers. Upper plasma plus Buffy coat, RBC settle at the bottom, and the upper layer with Buffy coat is transferred into the sterile tube. Second spin, further centrifugation separate platelet with the new RBC at the bottom, and upper platelet poor plasma is removed. Homogenization, platelet plate are mixed thoroughly with the lower 1/3 of the plasma, and upper 2/3 plasma is discarded. The final product is your 5 ml concentrated, which is ready to use. And the closed PRP, the principle, use pre-filled closed PRP kit with ACD solution or ACD gel. Less chances of contamination, closed system, it is acts faster, comparatively cheaper than automated kits, easy PRP draw if gel is layer is present, and good for small volume. And some clinical use, some kits. These are the Dr. PRP kit which is FDA approved. Now indication, PRP used in many conditions like osteoarthritis, knee, shoulder, for the pain relief and functional improvement. And it is PRP superior to high hyaluronic acid in the evidence results, placebo at 6 to 12 months. Tendinopathies enhance healing and pain reduction, significant release in the VAS score, and improve function. Ligament injuries improve healing, return to activity. MRI studies faster graft maturation and reduced laxity, and functional improvement was noted. In the muscle injury, faster recovery or less chances of re-injury. In the RCT, athletes return 7 days earlier versus placebo, and with the low rate of the recurrence rate. In carpal tunnel syndrome, pain reduction, nerve regeneration, PRP improved Boston CTS score and nerve conduction velocity at 6 months. Discogenic low back pain, pain relief and functional improvement. RCT significantly decrease VAS score, and plantar fasciitis effective in chronic resistant cases. PRP better than corticosteroid at 6 to 12 months. And non-healing ulcer and neuro regeneration is experimental use. Some case series was published in this show. Faster granulation wound closure improve healing time. Stem cells. So introduction and definition. Stem cells are undifferentiated cell capable of prolonged self-renewal and of differentiation into one or more specialized cell types. These are the self-renewal, can divide repeatedly without losing potential, can become specialized cells like bone, cartilage, muscles, nerve, and central to regenerative medicine, repair, replace or regenerate damaged tissue. Types of the stem cells. These are the embryonic stem cells derived from the blastocyst. Pluripotent, can form almost any tissue, and ethical and safety issues not used clinically. Adult stem cell, HSC, from the form blood cells established in hematological disease, and mesenchymal stem cells from bone marrow, adipose tissue, umbilical cord. This is the key in regenerative medicine. And induced pluripotent stem cells, somatic stem cells reprogrammed to pluripotency, mostly research, not yet in clinical use. Mesenchymal stem cells are multipotent progenitor cells of mesodermal origin that adhere to plastic, express CD73, CD90, CD105, and differentiate into osteoblast, chondrocyte, and adipocyte under standard in vivo condition. Sources: bone marrow, adipose tissue, umbilical cord, and properties: immunomodulatory, anti-inflammatory, on pro-angiogenic. Most widely investigated stem cells clinical use. So, allow established in India HSC hematopoietic stem cells routine for the blood cancer. Autologous minimally manipulated products like PRP, BMAC, and MFAT, and not allowed in clinically practice. Culture expanded MSCs, embryonic stem cells, and induced pluripotent stem cells. How mesenchymal stem cells work? They are paracrine. Trophic effect, secretion of the growth factor, various growth factor, and some anti-inflammatory action by reduction of the TNF and interleukin 1 and increase interleukin 10. Some immunomodulation, promotion of the M2 macrophage, support of regulatory T cell activity, and matrix remodeling, support extracellular matrix repair and recruit and activate local progenitor cells. What are the rationale in PMR? Adipose tissue contain more MSCs than bone marrow. Autologous use safe, no immune rejection, and biological effect: pain reduction, anti-inflammatory action, support of cartilage, tendon, ligament, and muscle repair. Some evidence support strongest in the osteoarthritis of the knee and tendinopathies, but still experimental in spinal cord injury, stroke, and neuro rehabilitation, and works best when combined with the rehabilitation program. So, bone marrow aspirate concentrate. A concentrate of the BMA containing multiple cell types including a small number of the MSCs, typically created through a centrifugation procedure. Marrow cell have anti-inflammatory, immunomodulatory effect and secrete growth factors, cytokines, and chemokines. It is obtained by iliac crest aspiration, the common source for harvesting mesenchymal stem cells, other progenitor cells, and associated cytokine growth factor, currently approved by FDA. If we talk about the content, BMAC content some yellow marrow, red marrow contain hematopoietic stem cells, mesenchymal stem cells, and primary aim to BMAC to increase MSC via the centrifugation. If we see the count in bone marrow aspirate is around 612 per centimeter cube, in BMAC is around 2579. A recent systemic review reported good to excellent outcomes with the use of BMAC for the treatment of local condyle support defect and mild to moderate osteoarthritis of the knee with a relatively safe profile. Growth factor, which is found in the BMAC, platelet derived growth factor, transforming growth factor, bone morphogenetic protein, 7, 2, and interleukin 1 receptor antagonist. Sources of bone marrow aspirate concentrate. The commonest site is iliac crest, tibia, calcaneum. Iliac crest yield the highest concentration of the MSCs, and the harvest techniques, graft is harvested by sector rule in iliac crest, divide into crest into 6 zones. The posterior iliac crest zone is the most preferred site. It contains 1.6 times higher concentration of MSCs compared to anterior crest. Now technique. First of all, patient position, select anesthetic plan for the aspiration. For the PSIS, harvest patient in the prone position, and for the ASIS, harvest patient in the supine position. Palpate site for the aspiration. Sterile preparation with antiseptic solution and sterile sheet towel should be used. Now bone marrow aspiration, confirm bony landmark, inject local anesthetics, preload aspiration series with the 1 ml heparin, insert aspiration trocar and needle through the skin down to the bone and penetrate cortex with the power tool. Collect approximately 60 ml of the bone marrow aspirate. Now preparation of the aspirate, centrifuge according to the protocol and obtain approximately 6 ml of the BMAC sample. Now application of the aspirate, select clinical indication like rotator cuff repair, ACL revision or osteoarthritis. Sterile preparation of injection site should be maintained, or inject local anesthetic if selected and inject aspirate into the selected site. BMA is filtered through the 200 micrometer mesh filter into the 50 ml conical tubes, and 60 to 90 ml of BMA is transferred into two 50 ml conical tube and initially centrifuged at 2400 rpm for the 10 minutes. And buffy coat layer and platelet poor plasma layer extracted from the conical tube and discarded, and second centrifugation around for the 3400 rpm for 6 minutes, and the final product is to inject. Now what are the advantages and disadvantages for the bone marrow aspiration, harvest and application? Advantage, technical easy to harvest, no culture expansion, no risk of allogenic disease transmission, low risk of infection, and may be performed with the concomitant procedure. And what are the disadvantage? Potential pain during harvest with the local anesthetic alone, variable stem cells quantity and quality depending on age, potentially detrimental effect of erythrocyte when used in intra-articular environment. Now rationale of BMAC in the regenerative medicine, cellular source provide MSCs that differentiate into cartilage, bone, tendon and muscle. Paracrine effect secrete growth factor and cytokine which promote angiogenesis, reduce inflammation and stimulate local repair. Immunomodulation, MSC modulate immune response, decrease inflammation and fibrosis. Microenvironment support, enhance extracellular matrix remodeling, support resident stem cells, and concentration advantage. Compared to bone marrow aspirate alone, centrifugation increase progenitor cell density and stronger regenerative potential. MFET, microfragmented adipose tissue. These are obtained from the patient's own adipose tissue. The process, gentle mechanical microfragmentation and washing, no enzyme, no additive, minimally manipulated products, preserve stromal vascular fraction inside its natural environment. What are the biological rationale? Rich source of the adipose derived stem cells, contain parasites, stromal cells and extracellular matrix. Function almost same, anti-inflammatory, immunomodulation, paracrine secretion and scaffold effect. What are the clinical application? It has been used in knee osteoarthritis, which was pain reduction, functional improvement, in tendinopathies for the rotator cuff, Achilles plantar fascia, and some spine disorder like early studies in degenerative disc disease. What are the advantages? It is autologous, safe and single step procedure, provides cells, growth factor, extracellular matrix scaffold together, and complies with regulatory guidelines. Limitations, variable yield depending on the adipose quality, require specific closed system kits, and current evidence, small ORCTs and case series, long-term studies required. Now prolotherapy, it's a part of the regenerative injection therapy, proliferative therapy, injection technique to stimulate healing of chronically injured ligament, tendon and joints. The definition, injection of the growth factor or growth factor stimulants or injection that cause growth of normal cell or tissue. Some another definition, Strengthen the weld of disabled ligament and tendon to bone by stimulating new bone and fibrous tissue cells. What are the mechanism of action? Local tissue irritation, controlled, which cause controlled inflammatory response. So first injection injury plus proliferation of the trigger inflammation. Within 6 hours, release of the growth factor. In day 3, granulation tissue formation. End of 1 week, fibroblast proliferation. And after the week to months, new collagen and stronger tissue formed. End results, tissue strengthening and pain reduction. Some proliferant solution used as a dextrose, which is most commonly used, 12.5 to 25%, most commonly safe or evidence-based. Chemical irritant, phenol glycerin, glucose, dextrose, and phenol glycerin. Some chemotactic agents, sodium morate, and biological agent, growth factors. But phenol and sodium are not now used in clinically. Some clinical indication, chronic tendinopathies like lateral epicondylitis, Achilles tendinitis, and plantar fasciitis, joint disorder like knee osteoarthritis, shoulder instability, spinal condition like sacroiliac dysfunction, ligament laxity, and chronic low back pain, other whiplash injuries, fibromyalgia in selected patients. What are the contraindications for prolotherapy in local infection or cellulitis, septic arthritis, progressive neurological deficit, and allergy to solution? Evidence, RCT support use in the knee osteoarthritis, tendinopathy, and low back pain. Some systemic review, safe, low cost, modest to moderate improvement in the pain and function, and strongest evidence for only dextrose prolotherapy. Some site we can use for the prolotherapy. Before giving any regenerative medicine, some checklist we should always go through at OPD. We should always take consent, patient having on a drug, anticoagulants, NSAID, and any oral hypoglycemic agents, any allergic history, if you want any need of antibiotics, and NPO required or not, bowel preparation required or not, anticipate procedure like positioning, local site inspection, review X-ray and CT scan, post-procedure mobility, whether relatives should accompany, and females pregnancy lactation status should always check, need for any anesthesia if you think, and complete diagnosis with comorbidity, anxiety, and depression. Pre-procedure, recheck checklist from the OPD, medicine equipment table, recording device, functional available, check investigation blood sugar, creatinine, PTINR, platelet count, and consider monitor IV line, preloading, confirm patient name and site of a site injection. It is essential, bladder empty or not, jewelry removed, and some aseptic or antiseptic protocol. And the post-procedure, expect side effect like motor power loss, hypertension, review for the complications, documentation and advice, and review plan for sick leave. Some rehabilitation, we should always focus on the rehabilitation after regenerative procedure. Regenerative injection like PRP, BMAC, MFET need biological healing time. It takes around 4 to 12 weeks. So our goal is protect repair site, control pain and swelling, maintain strength and mobility, and restore function gradually. So avoid NSAID, corticosteroid, early overload, and smoking. And protocol must be phase wise and condition specific, like which joint is treated, which tendon or spine. In first 48 hours, we advise relative rest, not complete bed rest. We should avoid heavy activity. If we prescribed any brace support, so it must be used. ADL allowed, but avoid lifting, twisting, and running or impact. And pain relief only for with paracetamol, avoid NSAIDs. And cryotherapy only for the comfort, do not overuse. In the next 1 to 2 weeks, we can start movement, range of motion like gentle, pain-free. For the joints, for the shoulder pendulum exercises, and for the knee heel slides, we can advise. Or for the spine, pelvic tilt, gentle lumbar rotation. We can start in this phase isometric exercises, which is like for the quadriceps, hamstring, gluteals, and abdominal wall. We can also emphasize the core activation at this stage, like transverse abdominal stretching, mini bridges. We also emphasize posture correction and diaphragmatic breathing. Our goal is to maintain mobility and muscle tone without stressing repair. In the next progressive phase, 2 to 6 weeks, we start isotonic strengthening like light resistance, high repetitions, close chain exercises we can advise. Spine specific exercises we can advise like curl up, side plank, It is excellent for the lumbar stabilization. Add low impact aerobic exercises like cycling, pool walking, and elliptical training. We should encourage balance between the loading for adaptation and always avoid the flare up. Functional phase in the next 6 to 12 weeks, dynamic strengthening for progressive resistance, compound movement, proprioception and balance, single leg stance, wobble board and unstable surface. For spine, resisted core exercises started, rotational control and advanced stabilization. For joint and tendon eccentric training, important for the tendons, and begin activity specific retraining like stair climbing, work drills, light sport drills. Our goals and this stage restore endurance and control and coordination. Return to activity, gradual return to the full work sport only if pain free and functional after around 3 months. Continue core and proximal muscle endurance training for the long term, and we always incorporate with the ergonomics, posture and lifestyle changes like weight reduction, smoking cessation, and monitor for any flare up like swelling, pain, stiffness. Modify your exercise or rehab protocol, and long term success always depend on exercise plus regenerative injection combination.
Just curious to know, you mentioned twice that post injection you should not smoke and pre injection smoking is a relative contraindication. Why is tobacco contraindicated?
So in general perspective, tobacco is hampered the healing process. Tobacco is smoking.
I wanted to ask how many, what is the duration between a PRP, each PRP injection we should keep ideally? Because in return to rehabilitation thing that lasts for 12 weeks around.
So for the next, it is around 3 to 4 weeks for PRP injection we should gap between 2 injections.
So how will we integrate that with the rehabilitation part for the patient? After all the sessions of PRP, should we initiate the rehabilitation or should
it depends. In some small injuries, we can use single or 1 to 2 injections, and for large joint, we need around 2 to 3 injections. So you plan your program according to that protocol.
So this is applicable to both like leukocyte rich and leukocyte poor PRP, like 3 to 4 weeks of duration.
Yes.
I think you mentioned prolotherapy as an indication for progressive neurological condition. Where exactly is it used?
So, it's not commonly used actually. This is only.
It was listed, or did I see it wrong? I'm not sure.
Yes, but not commonly used.
Okay.